The following podcast is part of a certified educational activity titled Navigating the Layers of Complexity in Relapsed and Refractory B-Cell Cancers, from clinical prognosis to emerging therapeutic prospects in CLL/SLL, MCL, and DLBCL. Access the entire activity and complete the post-test at peerview.com/AZC860. Downloadable practice aids are also available.
Hello, this is Dr. Toby Eyre from Oxford University Hospitals NHS Trust in the UK. Welcome to Navigating the Layers of Complexity in Relapsed and Refractory B-Cell Cancers. This program will feature an animated exploration of how management has and will continue to change in different B-cell cancers, including chronic lymphocytic leukemia, mantle cell lymphoma, and diffuse large B-cell lymphoma, with a particular focus on what these changes mean for sequential treatment in patients with relapsed and refractory disease. Our goals of today will be to help you understand the implications of prognostic and predictive markers for treatment decisions in B-cell cancers, to improve your knowledge of evidence supporting emerging targeted therapies and antibody platforms in these diseases, and to enhance your skills for developing individualized care plans for patients with relapsed and refractory chronic lymphocytic leukemia, mantle cell lymphoma, and diffuse large B-cell lymphoma. So let's take a start by looking at some factors that can help us decide on treatment, some of which will have implications for the first-line treatment setting, as well as those patients with relapsed and refractory disease. And so we're going to run through some prognostic factors in each of those three diseases I mentioned. To start with, we'll look at chronic lymphocytic leukemia. You can see here listed 5 prognostic factors: the CLL International Prognostic Index, or the CLL IPI, where age, stage, deletion 17p or p53 mutation, IGVH status, and beta-2 microglobulin levels were combined to create the CLL IPI. This was from an era of immunochemotherapy and has been replicated to some degree in an era of targeted therapy. The other important poor prognostic factor is complex karyotype. Now, I just mentioned p53. Here is an example where p53 deletion or mutation is important, particularly in the era of immunochemotherapy when it was used and patients had particularly poor outcomes. And although BCL2 and BTK inhibitors are effective in patients with p53 deletion or mutation, their responses are generally shorter, and often p53 disruption is seen to be an independent prognostic factor in patients treated with these agents. In mantle cell lymphoma, there are a number of established tools, and these include the Mantle Cell Lymphoma International Prognostic Index, where performance status, age, LDH, and white cell count have been validated in prospective clinical trials and retrospective data sets. The proliferation index is also an important well-established prognostic marker. Patients with a higher Ki-67, typically accepted as greater than 30, have higher risk disease. And when that is combined with the MIPI score, a biological MIPI is also a strongly prognostic index. The MIPI score can be often used both to prognosticate but also for stratification in clinical trials. There are other important factors that can inform prognosis in mantle cell lymphoma. The histological subtype of mantle cell lymphoma is very important. Blastoid and pleomorphic disease typically have inferior prognosis with immunochemotherapy and indeed with targeted inhibitors such as BTK inhibitors. Similarly, TP53 aberrations, particularly mutations, are associated with worse outcomes as well. This has been studied mostly with immunochemotherapy, and as you can see, the results are particularly poor with intensive chemotherapy, and when chemotherapy is intensified, outcomes are not improved, even for younger patients. So this represents a group with a great unmet need at present. In diffuse large B-cell lymphoma, the classical prognostic tool, which we have used for many years, is the International Prognostic Index, or the IPI, and this uses 5 key factors to calculate a patient's risk. These include age, performance status, LDH, extranodal involvement, and the stage of the disease. And these are often divided to help prognosticate clinically, to stratify patients within clinical trials, and also to guide therapy in limited stage disease, as well as potentially access to therapies or intensification of therapies in those with higher risk disease. There are some other well-known factors associated with worse outcome in diffuse large B-cell lymphoma. These include MYC and BCL2 rearrangements and the cell of origin, either calculated by the Hans algorithm or by gene expression profiling. And you can see that prognosis with patients with double hit and in those with non-germinal center or activated B-cell type diffuse large B-cell lymphoma are generally worse than the group without double hit or those with germinal center B-cell type diffuse large B-cell lymphoma. So let's turn to standard of care therapy for B-cell malignancies as reflected in practice guidelines. In many cases, our national and international guidelines have incorporated newer therapeutics and are informed by the results of prognostic assessment. So let's start with some recent guidelines from chronic lymphocytic leukemia. These are the recently revised ESMO guidelines for the management of first-line patients requiring treatment. And you can see now the importance of the IGVH status and TP53 mutation in dividing patients according to genetic risk. You can also see a division according to age and fitness, which is also important. Now, many of these therapeutic combinations or agents are appropriate for all groups of patients. And so you can see in these boxes, there are a number of therapies that potentially appropriate across the board, for example, BTK inhibitors as monotherapy. But you can also see a division where more fixed duration therapies are considered more appropriate in those with lower biological risk disease. For example, venetoclax obinutuzumab in IGVH mutated TP53 intact disease. Conversely, if you look at patients who have a TP53 mutation or deletion of 17p, you can see continuous BTK inhibitors are generally preferred, with data supporting acalabrutinib, zanubrutinib, and indeed ibrutinib. We see a similar pattern in patients with relapsed refractory CLL, where prognostic factors and, of course, the history of the treatments received in the first-line setting have a major role in selecting therapy. Now, a number of patients are receiving fixed duration therapy in the first-line setting, and this may well allow re-exposure to therapy in the relapsed refractory setting. So, for example, you can see patients who have a late relapse after first-line venetoclax-based therapy may be appropriate to expose to venetoclax-based therapy in the second-line setting before perhaps receiving a BTK inhibitor. Those with earlier relapse, however, after fixed duration venetoclax may be more appropriate for a BTK inhibitor. One interesting new finding here is the integration of non-covalent BTK inhibitors in the clinical pathway. Patients who progress off a covalent BTK inhibitor could potentially receive a non-covalent BTK inhibitor at subsequent lines, either before or after venetoclax-based therapy. So what are some other factors in CLL that may help guide how we select or sequence treatment in the future? In patients with CLL on continuous therapy with a covalent BTK inhibitor, we've long known that resistance mutations, primarily at the CYS481S binding site, have implications for disease progression and potentially the future choice of therapy. Covalent BTK inhibitors are unable to bind to the BTK binding site when C481S mutation is present. And this confers resistance to all classes of covalent BTK inhibitors, so ibrutinib, acalabrutinib, and zanubrutinib. Now, although resistance testing is not currently the standard of care, it may have clinical implications in the future and can also be used to document key biological resistance to covalent BTK inhibitors. Now, the CYS481 mutation is not the only mutation. There are a number of other mutations that have been described in the literature, and this includes the L528W mutation, which has been seen after zanubrutinib progression, and also the downstream PLC gamma 2 mutation, which can coexist with other BTK mutations, but can also be seen in patients who progress on a covalent BTK inhibitor. Now, I noted earlier that non-covalent BTK inhibitors are making their way into the European guidelines for CLL, and we'll talk more about the emerging non-covalent BTK inhibitors later. But one agent, pirtobrutinib, is authorized for mantle cell lymphoma in the EU and approved for both mantle cell lymphoma and chronic lymphocytic leukemia in the United States. We recently saw evidence of mutations that can also develop at progression with pirtobrutinib. A number of non-C481S mutations can confer resistance to pirtobrutinib and potentially other non-covalent BTK inhibitors, as well as the downstream PLC gamma 2 mutations, which can also occur in this setting. Let's review guidelines for other B-cell malignancies and starting with mantle cell lymphoma. Once again, newer therapies are being integrated into a space that was previously reserved for purely chemoimmunotherapy and autologous stem cell transplant. And you can see in this UK guideline the potential integration of ibrutinib following the results of the Triangle trial in combination with the R-CHOP component of R-CHOP/RDHAP induction, and then as maintenance therapy for 2 years has the potential to replace autologous stem cell transplant if a therapy is licensed and reimbursed. In older patients, the standard of care generally still remains immunochemotherapy, although BTK inhibitors particularly are challenging this treatment paradigm and may well in the future provide another option for patients in the first-line setting who are historically either unfit for autologous transplant or have comorbidities that preclude it. In diffuse large B-cell lymphoma, modern treatment is largely based on risk factors and stage and the patient's functional status, with new developments in the first-line treatment setting, including the use of Pola R-CHP, which contains polatuzumab vedotin, which is an anti-CD79B antibody-drug conjugate. Other options still include treatments such as R-CHOP or other more intensive therapies in higher-risk patients. In the second-line setting, we've seen the emergence of strategies such as anti-CD19 chimeric antigen receptor therapy or CAR T-cell therapy, as well as newer bispecific antibodies, monoclonal antibodies, and antibody-drug conjugates. Patients who typically relapse within 12 months of their first-line therapy should be considered for CAR T-cell therapy, given the overall survival benefit seen in large randomized clinical trials. We've gone through modern prognostic factors and options that are currently recommended for the management of several B-cell malignancies. What about the newer agents that are in development, and how will they inform future strategies for managing patients? Let's take a look at a few recent examples. I mentioned the emergence of non-covalent BTK inhibitors in CLL and mantle cell lymphoma earlier, and besides pirtobrutinib, other agents, such as nemtabrutinib, also being investigated in the post-covalent BTK inhibitor setting. Other BTK-directed options include a new class of agents called BTK degraders, which we'll also explore. Finally, we'll have a look at newer antibody-based approaches, including antibody-drug conjugates, bispecific antibodies directed against different targets. Let's start with non-covalent BTK inhibitors. I earlier noted that BTK CYS481S mutations confer resistance to covalent, irreversible binding BTK inhibitors. Non-covalent agents are specifically designed to overcome this challenge. They bind reversibly to BTK, not relying on the covalent binding site, and are able, therefore, to overcome resistance that is being driven by a CYS481 mutation. Pirtobrutinib is authorized in the EU for relapsed refractory mantle cell lymphoma, approved in the US for CLL and mantle cell lymphoma, and nemtabrutinib is currently investigational in clinical trials. This is a reversible non-covalent BTK inhibitor that was tested in the Bellwave 001 trial, which included patients with chronic lymphocytic leukemia and small lymphocytic lymphoma, as well as several other subtypes of B-cell non-Hodgkin lymphoma. In total, 35 patients were evaluated for efficacy, and 22 of those patients had chronic lymphocytic leukemia or small lymphocytic lymphoma. The overall response rate was 36% across all doses, and the overall response rate was 75% in the 8 patients with relapsed refractory CLL at 65 milligrams once daily. Nemtabrutinib was also active in a variety of other non-Hodgkin lymphoma subtypes, including Richter transformation, diffuse large B-cell lymphoma, and follicular lymphoma. Responses were durable in patients with CLL and in a heavily pretreated group of patients, both with a C481S mutation and those without. Progression-free survival was over a year. Nemtabrutinib toxicities were associated with well-known toxicities with BTK inhibitors. Neutropenia and infection were the most common adverse events, with other adverse events such as hypertension and atrial fibrillation and rash also seen. So what are the next steps for nemtabrutinib? A phase 3 study, the Bellwave 010 trial, is enrolling patients with relapsed refractory CLL and will test nemtabrutinib plus venetoclax versus venetoclax rituximab in the relapsed refractory setting. Venetoclax rituximab is a standard of care treatment in this setting, and this is a large randomized clinical trial with the primary endpoint in the second part of the study of progression-free survival. Another phase 3 trial, the Bellwave 011, will compare nemtabrutinib with an investigator choice covalent BTK inhibitor, either ibrutinib or acalabrutinib. Approximately 1,200 patients will be enrolled in this trial, and the primary endpoints are overall response rate and progression-free survival. As I mentioned, there are other ways to target BTK, and recently we've seen the development of BTK degraders. Some agents in this class can be classified as proteolysis targeting chimera molecules or PROTAC molecules. Degraders cause the degradation of the BTK protein through the ubiquitin proteasome system. The components of the degrader are shown here in this figure. There is a ligand binding to BTK, the BTK hook, a ligand that binds to E3 ligase, and a linker, as you can see here. The degrader binds to BTK, and this leads to ubiquitinization. Following ubiquitinization, this leads to BTK being degraded by the proteasome. A number of BTK degraders have been tested in relapsed refractory chronic lymphocytic leukemia, including in heavily pretreated patients exposed to multiple lines of therapy, including covalent BTK inhibitors, non-covalent BTK inhibitors, and venetoclax. Two compounds in active development include NX-5948 and BGB 16673. NX-5948 demonstrated a response rate of 77% in 30 evaluable patients with heavily pretreated CLL and unfavorable genetics, and also those who've been exposed to covalent and non-covalent BTK inhibitors. And BGB 16673 also demonstrated similar efficacy in 49 patients who were also heavily pretreated, exposed to those similar classes of agents. Earlier, I highlighted the movement of antibody-drug conjugates such as polatuzumab vedotin into the guidelines of patients with diffuse large B-cell lymphoma. Other ADCs with the applications in B-cell cancers have also been developed to target different aspects of malignant cells. And one intriguing target is the receptor tyrosine kinase-like orphan receptor 1, or RO1, a cell surface protein expressed on malignant cancer cells. This can be targeted by an antibody-drug conjugate called zivertamab vedotin. Zivertamab vedotin is a novel ADC comprised of humanized monoclonal antibodies zivertamab and a proteolytically cleavable linker and a cytotoxin MMAE. Zivertamab vedotin binds to the RO1 expressing tumor and results in rapid internalization, trafficking to the lysosomes, and antibody drug conjugate cleavage and MMAE release, resulting in cytotoxicity. Early evidence with zivertamab vedotin suggested its activity in heavily pretreated patients with mantle cell lymphoma and diffuse large B-cell lymphoma. In 15 patients with relapsed refractory mantle cell lymphoma, the response rates were just under 50%, and in relapsed refractory diffuse large B-cell lymphoma, the overall response rate was 60% in a small number of patients. This encouraging early efficacy has led to further development with this molecule in combination with R-CHP in diffuse large B-cell lymphoma in a phase 2 open-label study, the Waveline 007 study. The results from this study showed that zivertamab vedotin in combination with R-CHP achieved a response rate of 100%, all of which were complete responses in patients treated with 1.75 milligrams per kilogram of zivertamab vedotin, demonstrating efficacy in this first-line treatment setting. And based on this, zivertamab vedotin plus rituximab and CHP being evaluated in the phase 3 Waveline 010 trial versus R-CHOP in newly diagnosed diffuse large B-cell lymphoma. Finally, let's take a look at newer bispecific antibodies in development for B-cell malignancies. In diffuse large B-cell lymphomas, CD20 and CD3 bispecific antibodies, such as epcoritamab and glofitamab, have been studied and authorized in patients with relapsed refractory diffuse large B-cell lymphoma in the EU. A newer bispecific antibody, AZD0486, is an IgG4 fully human CD19-CD3 bispecific T-cell engaging antibody with low affinity at the CD3 binding site. Now, this low affinity binding to CD3 is thought to reduce cytokine release syndrome, and we know that CRS with currently available bispecifics is a consideration during specifically the dose step-up period. In relapsed refractory diffuse large B-cell lymphoma, AZD0486 has shown clinical activity in heavily pretreated patients, including both CAR-T-exposed patients and CD3-CD20 bispecific antibody-exposed patients in diffuse large B-cell lymphoma. Let's conclude by revisiting some of the earlier algorithms I showed you and speculate on where potentially some of these newer modalities might play a future role in disease management. In relapsed refractory CLL, for example, it's possible that we may see an expanded role for non-covalent BTK inhibitors and potentially the inclusion of BTK degraders in the future. Similarly, in diffuse large B-cell lymphoma, newer ADCs such as avelumab vedotin and newer bispecific antibodies such as the AZD0486 molecule could also add to existing strategies in both newly diagnosed diffuse large B-cell lymphoma and also in patients with relapsed refractory disease, potentially providing more treatment options for clinicians and patients in the future. So that concludes a walkthrough of recent agents in development in B-cell malignancies. Targeting BTK has been generally through covalent BTK inhibitors until recently, but newer agents such as non-covalent BTK inhibitors and BTK degraders are both active following covalent BTK resistance and may well play a very important role in relapsed refractory disease in the future. Newer ADCs are in development, and avelumab vedotin is an active agent in diffuse large B-cell lymphoma, and the results of the first-line randomized trial will be very important moving forward to see whether this agent can be integrated into our treatment algorithms in combination with chemotherapy. And targeting CD19 with bispecific antibodies is a novel approach. We have seen anti-CD19 targeted CAR T-cell therapy be successful over recent years, but off-the-shelf CD19 targeting therapy may be active, particularly in patients who become resistant to CD20 targeted bispecific or monoclonal antibody therapy. And the potential for CD19 targeting therapy is across a range of diseases, including diffuse large B-cell lymphoma, potentially mantle cell lymphoma, and chronic lymphocytic leukemia. Thank you very much for listening and for your attention, and I hope you have found this program useful.
Thank you for listening. Remember to download the practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co, Incorporated. To access all materials for this activity, visit peerview.com/AZC860.